Hello, welcome back to Risk Management. Today is part 2 of randomized controlled trials, establishing causation the best we know. The question we're going to talk about today is, can a careful, large-scale randomized controlled trial work to establish causation? In the last class we talked about R.A. Fisher, the statistician who in the 1920s examined manures to see if in fact he could improve crop yields. And he concluded that by randomizing treatment and randomizing crop rotation, he could in fact create a statistical condition where confounders and reverse causation could be ruled out, and he could in fact determine that manures of certain types were better at creating crop yields than others. Now, I want to turn to a more modern example of this, one that Sir Richard Peto in a paper writes about in 1995. Peto asked the following question: will a medium-dose aspirin regimen reduce heart attacks in patients who have acute coronary heart disease? This seems like a straightforward enough question. Why would we maybe suspect this? Well, from a mechanism standpoint, aspirin tends to be a bit of a blood thinner. And we might think if your blood were a little thinner, there might be less clotting, and therefore less risk of heart attack. There's an intuition to it. It sounds good on the surface, but do we actually know that to be true? We need to be cautious because sometimes things that seem to be true are in fact illusions, causal illusions. We'll see some of those at times throughout this semester. But back to this question. Do we know that taking aspirin can reduce your risk of a heart attack if taken in a medium dose? Well, I want you first to look at this advertisement because Bayer Aspirin certainly thinks that you should be able to use it for that. And here's an advertisement proving that they think that.
None of us think bad things are going to happen to us. I'm here at my house on Thanksgiving Day, and I have a massive heart attack right in my driveway. An artery in your heart is called the widowmaker, and mine was 95% blocked. They took me to the hospital, and the doctor put me on a Bayer aspirin regimen.
Aspirin is not appropriate for everyone, so be sure to talk to your doctor before you begin an aspirin regimen.
I'm a blue-collar worker. To me, Bayer aspirin is another tool. Go talk to your doctor. You're not indestructible anymore.
Okay, now that we've seen the hype, what's the substance behind it? Is this actually true, or is Bayer a snake oil salesman selling us something that makes us feel better but does nothing for us in terms of actual results? Is this false advertising that Bayer should yank off the air, or are they justified in making the claims of this ad? This comes back to risk communication, something we'll talk about later this semester. It turned out that before 1988, aspirin was not routinely used in preventing heart attacks in hospitals. There had never been a major randomized controlled trial, an RCT, to assess whether aspirin was effective in reducing the risk of heart attacks. So, in that year, the question was asked, does a medium dose aspirin reduce the risk of stroke or heart attack in people at high risk for these vascular diseases? There was a study conducted called the ISIS-2 study, the second international study of infarct survival or heart attack survival. This study admitted over 17,000 patients into it to study. These were people who had been admitted to hospitals who had suspected acute myocardial infarction, blockage of the heart, and heart tissue death due to insufficient blood supply. They were not having heart attacks, but they thought that they were having heart tissue death at that time. When these individuals were given randomized assigned treatments, there were 4 different possible treatments that they could be given. 25% of them randomly got aspirin, 162 milligrams a day for 1 month long after discharge from the hospital. 25% of the people randomly got a one-time shot of streptokinase. It's a kind of clot buster that 2 out of every 3 in 1,000 people who get it will actually suffer an adverse effect of a hemorrhagic, a bleeding out stroke because of the use of this. It seems very traumatic. Why would we treat people with something like streptokinase if we know it's going to cause people to bleed to death? But the answer is because if only 2 to 3 out of 1,000 of them will bleed to death because of this, there must be a higher number of them that in fact will be saved from heart attacks. Third, 25% of the people enrolled in the study got got both aspirin and streptokinase as treatments. And then finally, 25% of the people who were enrolled in the study got neither aspirin nor streptokinase. They just got ordinary hospital care for their heart condition. Now you'd say, why wouldn't they treat them with these? The answer is because no one knew at the time if these treatments were effective or not. People wanted to study whether in fact this causal relationship was true. The other point to remember here is this was randomized treatment. The doctor didn't get to pick which treatment to give a specific patient. The patient came in and by complete lottery was assigned one of these 4 treatments for all 17,000 people in the study. This is the randomized part of the trial and the controlled part. The doctor doesn't get to choose or in some way affect the process by which people get it. This randomization cancels out confounders. And what did they find? Well, looking at this, here's another diagram of the types of treatments that were given. Aspirin, aspirin plus streptokinase, streptokinase alone, or nothing. And 17,000 people, a large number, which will be important for us to understand why that's important in the future, received these treatments. And here's the results diagram. There are 4 curves here in this diagram on the left. On the bottom horizontal axis, this is the number of weeks from the start of treatment until results were acquired. And then on the left axis, the vertical axis, it's the percentage who had died. Now, if we look at this, the 4 different curves are very indicative of which is the more effective treatment than the other. Notice the bottom curve. Routine care plus a combination of both streptokinase and aspirin. Only 8% of people died after a 5-week period. The next curve up is a treatment only with streptokinase. The next curve is aspirin alone. And finally, the highest curve, where the most people had died, was routine hospital care alone. When we're interpreting these results, Peto indicates that the 1-month mortality results are indicated. Aspirin alone and streptokinase alone were both highly significantly better than doing nothing for these patients. And the combination, taking both aspirin and streptokinase, was highly significantly better than either aspirin or streptokinase alone. In other words, 5% fewer overall numbers of people died by giving both streptokinase than aspirin than simply admitting them to the hospital. Now 5% overall difference doesn't sound like much, but if you add up the numbers, it's quite significant, as you'll see in a few slides. What I also want to say from this is the important part of this table here is the part in yellow towards the bottom of the page. They also did this study involving low-risk patients, people who were not suspected to be having heart conditions. And what they looked at here, looking at 30,000 people over a 5-year study, was there really was very little improvement in terms of heart condition for people without suspected existing heart conditions. Only 4 per 1,000 heart attacks were avoided as a result of using aspirin in low-risk patients. But to return to this study, here's the interesting part of the timeline. In 1987, only 10% of hospitals in Great Britain used aspirin routinely in acute coronary care. In 1988, this study that I've just described to you had its results published. In 1989, 90% of British hospitals started using aspirin routinely in acute heart attack care. What happened? Did people just catch on to a hot trend overnight? Did this become a fad? Did Bayer put out its advertisements and everybody just jumped on board? No. People recognized the statistical truth and power of randomized controlled trials, and this was an effective one, done with large numbers of patients, and so the results were convincing, and hospitals accordingly adjusted their care to reduce the mortality of their patients. Here's what Peto has to say about this. Since aspirin treatments do not appear to increase non-vascular mortality, that is, since there's no side effects that they can tell of when it comes to aspirin treatment, all-cause mortality is also significantly reduced. In principle, these findings could, if appropriately widely exploited, avoid about 100,000 vascular deaths, that is, strokes or heart attacks, a year in developed countries alone, and there are probably at least as many vascular deaths in least developed countries. In other words, just by using aspirin, or aspirin in conjunction with streptokinase, Peto says, we could avoid about 200,000 deaths a year from heart attacks and strokes. This is a table that shows Peto's estimate of roughly how many lives would be saved each year in each European country as a result of simple aspirin treatment routinely for people at high risk of heart attacks. Finally, what I want to talk about in looking at randomized trials is that they don't always have to be organized or systematically performed in order for a randomized trial to occur. Sometimes these occur naturally, and intelligent scientists can recognize conditions where randomization has occurred, exploit those conditions to create an experiment, and then interpret the results. This happens sometimes completely unintentionally, such as in the 1970s when the British Health Service was offering services for psychiatric care. In this case, the question that was asked causally was, does voluntary psychotherapy reduce or relieve mental disorders? Here's what happened in this case. The British Health Service offered free psychotherapy to everyone who applied for it, and 20,000 people signed up to get this care through the British Health Service. However, due to budgetary constraints and cutbacks, the British government slashed the budget for psychotherapy for the health service, and the expected amount of money was not available. About only half the money was available, and therefore only about 10,000 of the 20,000 who had signed up could in fact receive treatment. The British government, trying to be fair, held a lottery, and some scientists realized this created a very nice randomized trial. Half the people who were willing to get treatment were given treatment, and half the people who were willing to get treatment did not get treatment, not through anything of their own making, but because of an outside random factor, a budget shortfall. So, they followed up with these patients, the treated and the untreated patients, to see how their mental health conditions were. And they found interesting results. Treated individuals had improved mental states. But what was interesting about this study was that untreated patients who had been enrolled to get health care but were denied it because of the budget shortfall also had improved results at about the same rate as the treated patients. Because of the randomization, this allowed scientists to be able to recognize that health care, or at least the psychotherapy that was being offered in Britain at that time, did not improve the actual conditions of the patients. What mattered was the fact that you recognized you needed that treatment and signed up to get it. If you were in that condition already, where you realized that your mental health had deteriorated to the point that you needed treatment, you were already on your way to recovery. And this was a very nice randomized trial, not set up intentionally, but discovered creatively by scientists to address the question of whether voluntary psychotherapy relieved mental health conditions. What we can take from today's lessons is that randomized trials are used frequently and widely to test causal questions. Many associations exist out there, but as we know, association is not causation. In order to move from an association to a causation, an ideal way of doing so under many circumstances is by a randomized controlled trial, such as the aspirin one that was done in the IS-IS2 study. Okay, we're done for today. Let's see what questions you have on the chat boards, and I'll look forward to seeing you next class.